Let's review the image analysis for the shoulder. We are working on the AP oblique projection of the Gracie method for the glenoid cavity. Image analysis guidelines for the AP oblique Gracie method state that the glenoid cavity is demonstrated in profile and the glenohumeral joint is open. 1/3 of the coracoid process should superimpose the humeral head. The glenoid cavity should be demonstrated without thoracic superimposition. The clavicle will be foreshortened and is horizontally situated. In a patient who is recumbent, the glenoid cavity will be situated slightly superior and the clavicle will be foreshortened and aligned vertically and superimposing the scapular neck. The superior margin of the coracoid process will be aligned with the superior margin of the glenoid cavity. The glenohumeral joint will be at the center of the exposure field. The glenoid cavity, humeral head, coracoid, and acromion processes and lateral clavicle are all to be included within the exposure field. You can review the image analysis guidelines at your leisure. So let's talk about some common positioning errors. In excessive torso rotation, the glenohumeral joint space will be demonstrated as closed, as you can see here. Okay, I'm trying to put an arrow there for you. Okay, and more than the 1/3 of the lateral coracoid process will superimpose over the humeral head. As you can see, this coracoid process is superposing over this humeral head excessively. In order to correct this, we need to decrease the amount of torso and shoulder rotation for this projection to open up that glenohumeral joint space. In insufficient torso and shoulder rotation, that joint space, that glenohumeral joint space, will be closed again. And less than 1/3 of that coracoid process will superimpose that humeral head. This should let you know that we need to increase the rotation of the patient in order to open that joint space. So let's take a look at our first practice analysis for the Gracie method. Image analysis guidelines, the objective in this projection is to get that glenohumeral joint space free of superimposition, and we want a nice open joint space here. At first glance, I can see that that joint space is not open. Okay, so now we need to determine, is there some rotation issues? When looking at the coracoid process and its relationship to the humeral head, it is in insufficient torso rotation. How I know this is that the coracoid process is superimposing less than 1/3, or 1/3 of it is superimposing, less than 1/3 of the coracoid process is superimposing the humeral head here. So we need to increase rotation to open that joint space. Another positioning error is also that mid-coronal plane tilt. The upper portion of this coracoid process right here should be aligned with the glenoid superior margin of the glenoid cavity here. And see, we have some distance, which should indicate to you we have a little bit of upper mid-coronal plane tilt, which is posterior. So you want to ensure that that patient's MCP is parallel with the IR when taking a corrective repeat image. In our next image analysis, again, we want to look to see, did we get the appropriate anatomic structures on the projection, and is our glenohumeral joint space open? And unfortunately, we got the anatomy, but the joint space is not open. So the first thing we want to look at is the position of that coracoid process. And when looking at that coracoid, you can see that the process is superimposing more than that 1/3, that 1/3 of that process is superimposing that humeral head in excess. And so the patient is in excessive obliquity. We need to decrease that patient's obliquity to get that joint space open. Let's move on to the image analysis of the scapular Y projection. Image analysis guidelines state that the scapular body should be demonstrated in a lateral projection with superimposed lateral and vertebral scapular borders. Scapular structures form a Y with the scapular body as the leg and the acromion and coracoid processes as the arms. The glenoid cavity should be demonstrated on end at the converging point of the arms and legs of the Y. When there is no injury, the glenoid cavity, humeral head, and scapular body and humeral shaft are superimposed. When there is a shoulder dislocation, the glenoid cavity does not superimpose the humeral head. It'll either be projected anterior to the scapular body or posterior. When there's a proximal humerus fracture, the glenoid cavity will superimpose the humeral head. However, the scapular body doesn't superimpose the humeral shaft. The shaft will be dislocated. The scapula should be demonstrated without longitudinal foreshortening. The clavicle and superior scapular angle are visualized at the same transverse level. The mid-scapular body should be demonstrated at the center of the exposure field. The scapula, including inferior and superior angles, the coracoid, acromion processes, proximal humerus should all be within the exposure field. Here are those guidelines for you to review at your leisure. When identifying scapular borders, consider that the lateral border is thick, as you can see pointed here, with two cortical outlines that are separated by approximately 1/4 inch, okay? Whereas the cortical outline of the vertebral border or the medial border will demonstrate a single thin line. So let's talk about some common positioning errors. In excessive torso and shoulder obliquity for the scapular Y, the lateral border will superimpose the thorax as seen here. So this is your lateral border. Or it'll be positioned closer to the thorax than that vertebral or medial border as seen here. And you can see it is the medial border because we just discussed how the medial border demonstrates that single thin line. Also, the glenoid cavity will rotate in the same direction as the lateral border, indicating to you if it's closer to the thorax, it is definitely an excessive rotation. In insufficient torso and shoulder rotation for the scapular Y, the medial border or vertebral border will superimpose the thorax, and it will be demonstrated closer towards the thorax than that lateral border, as you can see. Also, the glenoid cavity will rotate in that same direction of the lateral border, which should indicate to you that there is insufficient rotation here. We need to increase rotation. In our first practice analysis, we want to make sure we have all our anatomic structures, which the entire scapula Y is on the image, and the humeral head and shaft is on the image. However, we do have some rotation issues because the vertebral and lateral borders are not superimposed. You can see that the lateral border is away from the thoracic cavity here, which should indicate to you we're in insufficient obliquity. We need to increase patient obliquity to obtain the appropriate projection. Another common positioning error can be mid-coronal plane tilting in the scapular Y as well. So we have to make sure that the patient's mid-coronal plane stays aligned parallel with the IR. How we can tell this is by looking at the superior angle of the scapula. It should not be above that mid-clavicular end here, okay? It should be in line. When you see that, but you have a perfect Y, it's because we have this tilting. And so we need to take a repeat and get that patient aligned appropriately with the IR. In our last practice analysis, again, we're looking for the vertebral borders and the lateral borders of the scapula to be superimposed. Utilizing our rule of thumb, the thicker border, which is right here, is our lateral border, and it is closer to the thoracic cavity, which should indicate to you that the patient is excessively rotated. We need to decrease that patient's obliquity so that we can get those borders superimposed. This concludes the image analysis for the shoulder. If you have any questions, please feel free to reach out to me via email or at clinic. Thank you for participating in the image analysis.